All right, so we are going to be talking about perfusion part one. Um, so for just an overview, we got to review anatomy and physiology to know how things are going on. Primary purpose of the cardiovascular system is to deliver oxygenated blood to the tissues and take deoxygenated blood back to the heart. Vascular system, we have arterial and venous. Our arterial is high pressure. We have thick walls. It allows us to vasoconstrict and vasodilate. And this will usually carry oxygenated blood from the heart to the tissue. So we go away from the heart. Our venous system is low pressure. We also have valves to prevent backflow. And this is always going to be delivering to the heart, almost always. The really fun thing about this is because of the valves, whenever our muscles contract in our lower legs, that's what actually pushes the blood up and the valves catch it. So this is also why our patients will get blood clots if they're not moving, because that blood just sits there. And we know when blood sits, it likes to coagulate or clot. So our capillary bed, this is where the actual oxygenation, tissue supply, and reabsorption of waste and CO2 occurs. And there are a couple million of these throughout our body where our veins and our arteries kind of mix and meet. Anatomy of the heart, we need to know this because when we're talking about certain diseases, we could have a problem with pericardium, like pericarditis, or the actual muscle, like myocarditis. Um, you're not going to be asked an actual question about these, but if you don't know what's going on, you won't know when something's wrong. We need to know the four heart chambers and the valves. This is specifically because when we talk about heart arrhythmias, heart disorders like heart failure, we need to know how the blood moves because then it's going to move incorrectly. We need to know how the blood moves because when something goes wrong, such as having a valve problem or a septal defect, we're going to see those symptoms and we need to know what's happening anatomically. We need to know about this for CPEB, which is your head to toe assessment. One of the things you're going to be taught about is assessing the different heart sounds. You are expected to know this for exam two. We have our aortic, our pulmonic, our tricuspid, and our mitral. I learned all physicians take meds. I know another one Galen will say is all people enjoy Taco Monday. Our mitral valve is also known as our apical pulse. But the reason we need to know this is aortic is going to actually let you hear the closest area to the aortic valve opening and closing. So we listen to these heart sounds because we don't actually hear the muscles contract. What we hear is the valves opening and closing. So each of these are the aortic valve, the pulmonic valve, the tricuspid valve, and the mitral valve. Herb's Point, specifically named after, I can only assume Dr. Herb, because they love naming things after themselves, is one of the places in the body that's the best place to hear S1 and S2. So it's the one area that is easiest to hear all the heart sounds. So that is sometimes covered. But each of those sounds lets you hear a specific valve. And if there is a problem with the heart, or we have some sort of murmur, you'd be able to hear that in those specific areas. So the only two normal heart sounds are S1 and S2. And that's what going. So S1 is our mitral and our tricuspid, and S2 is aortic and pulmonic. The other heart sounds are abnormal and only happens. S3 is usually heard after S2. It's a abnormal heart sound with blood rushing into the ventricles. It's usually found with heart failure or fluid overload. And there will be a third sound directly after S1. So it'll be bum bum, bum bum bum, bum bum bum, bum bum bum. A description would be like Kentucky, Kentucky. We have that sound directly after that S2. So it's S1, S2, S1, S2, S3, S1, S2, S3. And you'll hear that extra sound. That's S3. Um, We don't really like S3. S4 is also another abnormal heart sound. It will happen directly before S1. So we'll have S4, S1, S2, S4, S1, S2, or Tennessee, Tennessee, Tennessee. We have that extra sound. This occurs when when the atrial contracts, resulting in blood entering the ventricles. This happens with long-term hypertension, heart attack or MI, and ventricular hypertrophy. So S3 and S4 are abnormal heart sounds or murmurs when there's something anatomically happening with the blood moving incorrectly within the heart, and you can hear those heart sounds. A murmur is any abnormal sound usually caused by turbulent blood flow, and it's usually described as blowing, hissing, musical, or rumbling. This can be valve stenosis or hardening of the valves where they don't open correctly, valve regurgitation where they don't close properly, valve prolapse where they collapse, endocarditis, which is inflammation of the valves, pericarditis, which is inflammation around the entire heart, or septal defects. And septal defects, if we go back to, probably, sorry, it was here. Septal defects, this septum is usually open. And this happens a lot of times with itty bitty babies. And our oxygenated blood is going to go to the unoxygenated area. We know this is a septal defect because you'll have itty bitty babies who aren't playing or laughing because they can't breathe. Those are surgically repaired. They're almost always found when they're very young. But that would be our septal defect. I remember him as a septum piercing is going to go through the lining between your two nostrils. So it is that barrier between two cavities. On your PowerPoints, you can review any of these if you so choose, going over different rhythms. Coronary circulation is the actual blood flow to the heart. And when those coronary arteries are blocked, it's going to lead to coronary symptoms and eventually a myocardial infarction or heart attack. We're not going to be going over heart attacks this term. You will cover it in MedSurg 2. Super fun. But a fun fact is this left anterior descending is sometimes called the widowmaker because this feeds majority of the heart, and if that gets blocked, it usually dies. And who usually has heart attack? Men, and they leave widows. Fun fact. So if you ever heard a widowmaker, that's what they're talking about. So, cardiac output. This is not necessarily a math equation, but this is going to kind of help you understand what's going on. So, cardiac output is the total output that the heart does, and this is directly caused by heart rate times stroke volume. Stroke volume is how efficient the heart is, and there's three things that make up stroke volume. Preload, the amount of pressure coming into the heart. Afterload, the amount of pressure the heart has to work against. And contractility, or how strong each heartbeat is. So whenever the stroke volume's not doing good enough, the heart rate will go up to try to compensate. This is why we'll have, pro athletes who have a resting heart rate of 60 or 50 because their stroke volume is so good, the heart rate doesn't have to do a lot. Conversely, this is why we'll have like our 103-year-old patient with heart failure and liver disease who has a resting heart rate of 120 because the heart rate has to work so hard. For stroke volume, there's a little bit more the body can do versus just make it faster or slower. Preload and afterload are going to be based off like our renin-angio system. So are we going to contract the blood vessels? Are we going to vasodilate? Are we going to hold on to water? We have our vasopressins. All those hormones we talk about. And we're going to see a lot of the same symptoms when we talk about our heart rhythms because there's only really two things your body can do to fix blood flow issue. Make the heart go faster or slower, or affect the stroke volume. And affecting the stroke volume is usually holding on to fluid or getting rid of fluid. That could be our kidneys, that could be our heart, our adrenal. Contractility is really hard to do. That's making each heartbeat more efficient. There is only one drug that causes contractility, and that's our digoxin. That's the only drug that actually makes the heart more efficient. The body will do what's called hypertrophy, which is build more muscle, but that doesn't really help with contractility because conversely, the body now has to feed more heart muscle. So contractility is usually going to be the deciding factor, and that's usually what results and we see that problem with. But we'll talk about more of the diseases. So when we're talking about our heart arrhythmias and all our heart issues, we're going to see a lot of the same diagnostics because at the end of the day, the heart don't work and we got to figure out what's going on. So we got our laboratory markers, our troponin, our lactic acid. We're going to be looking at our cholesterol and our maybe our blood sugars, our acute cardiac damage or injury, our troponin and our lactic acid imaging studies. This could be our x-rays, this could be CT scan, MRI, our radiology. We got our echocardiography, which is actually seeing the movement of the blood with our ultrasound. And then we have cardiac stress test. That's a super fun one. We are going to make the heart work super, super hard and see how hard can it go until something gives up. So usually we will put them on all these heart monitors and we will have them run on a treadmill until they pass out or something gives. And we're pretty much seeing how much stress can the body do. If our patient can do that, we will just give them a shot of epinephrine because that's going to make the heart work 120%. We will always do this in a hospital because there's a good chance we might cause a heart attack or a heart arrhythmia or something like that. And we have to be watching that. But that's the best way to let us know what the problem is. I always think it's funny because I don't feel like the doctors explain how dangerous that is. But we got that. Catheterization is another really, really accurate way. This is where we are going to put an IV line or a sensor on a long metal thin rod and shove it through an artery or vein all the way to the base of the heart. Because of this, because we are putting a catheter inside the working pumping heart, because we can't turn off the heart, there's a good chance we might have life-threatening bradycardia. The heart will not get like getting stabbed and will stop. So we got atrophy because the heart needs to keep going. Um, there are some big safety things that can happen. We have infection because the blood in the heart is supposed to be sterile. We have possible um, clotting that can happen, whether that's a clot aneurysm or a pulmonary aneurysm or an air embolism, because it could, the catheter could break off or something could be on that. So we're worried about that. There's also possible damage to the tissue, internal bleeding from scraping or ripping on the veins or the lungs. So usually we'll do angiography, which is going to be so with angiography, we will actually put contrast into the heart. Again, contrast, we have that possible allergic reaction. Contrast is also really, really toxic to the heart. So we will sometimes do that as a precursor because it's less dangerous than catheterization, and that's usually going to show a possible problem, such as a septal defect or a valve problem or something like that. And it's a safety thing. Both of these do require consent and a lot of safety things with that. So keep that in mind when we talk about nursing. Heart catheterization and angiogram are here in case you need it. Other thing to talk about is our deconditioning. Our older adults are more likely to have cardiac problems. The ventricles and muscles become weaker. We have that atrophy. We have that decreased elasticity. The valves become more rigid. Heart disease is the #1 cause of death in our 65 plus community, and we know men are more likely to have it than women. All right, so now we get to talk about the fun stuff. We get to talk about the electrical activity of the heart. So electrical activity of the heart is going to move from the SA node to the AV node to the Purkinje fibers. And the excitability is how good the cells are at responding to the electricity, and the conductivity allows the heart cells to actually transport that electrical activity. Again, we want to talk about this. We know any cell within the heart can act as the pacemaker or the leader. That's one of the really good things. We do know the heart moves, the electrical activity moves in a very specific way. And we can only see the electrical activity when we have our EKG or another sensor. We can't see it, listen to it, or anything like that. So this is why we do our EKGs, because if there is a electrical problem, we need to be able to fix it. And this will help us know, is the problem with the electrical system, or is the problem with the actual muscles that they're getting the signal, but they're not responding? Either way, we're going to be able to fix it. But it's a pretty non-invasive way we can monitor heart function. So we have pretty much three things. Our SA node, if you've ever heard of sinus rhythm or sinus bradycardia, it is controlled by the SA node. And if you look at it, that's our normal, healthy heart rate range, normal 60 to 100. My AV node, the base resting heart rate, can only do about 40 to 60. So we can see this is why our AV node is our backup, our number two. They're better than number three, but they're not as great. Patients can have. So if you think about, if you ever heard of ventricle rhythms, like our VFib or VTAC, they are controlled by our AV node. Our Purkinje system is the very last one. Per your book, it's actually 20 to 40 beats per minute. Our patients don't really tend to last with a resting heart rate of 20 to 40 beats a minute. So usually we will need to place a pacemaker or something like that. But we have three backup systems your body does have. If for whatever reason the SA node doesn't work, AV node takes over. If the AV node doesn't work, we got our Purkinje system. Um, Again, we're going to step in if the AV node doesn't work because we do not like the Purkinje system to be in charge. They're a little slower than what we'd like. But again, we have the different resting heart rates. So EKG. We're going to have this lovely little strip. Usually our EKG strip is going to be 6 seconds unless it tells us otherwise. And we got to do a little bit of math. So when we look at our lovely boxes here, we have our itty bitty box, and then we have our big box. And so that's what we talk about for a box. So each itty bitty box is 0.04 seconds. And there are actually 5 in here. Let's see. 1, 2, 3. Supposed to be 5. And we know 4 times 5 is 20. So 0.04 times 5 is 0.20. So each of those little boxes is 0.04 seconds, and each big box is 0.2 seconds. We need to know this because we have certain ranges of what is acceptable levels. It does not matter how short or tall the heart rhythm is. What matters is the x-axis or how long they are. That's how we calculate. The height is going to pretty much tell you how close the sensor is to the heart. Some of you might say, hey, I've heard of ST elevation or ST depression, and that's specifically the ST is elevated. So for example, ST elevation is going to be elevated from the baseline, and that's not the height of it. ST depression is again going to be below that. And you'll talk about that more for med surg too. That's just telling me that the cardiac Electricity doesn't travel well through dead or dying tissues, and so these two things tell me something's wrong with the cells. You don't need to know this specifically. Now, if you need to, on page 641 and 642, your book goes in more details over these things. But we need to know the different things, and they will always be in this order. We got our P wave. That's that first little dot. That's going to tell me the atrium is contracting. The QRS is a big one because it's describing the ventricles, and the ventricles are big. So we will actually have where it goes up, it goes down a little bit. So we got our P, and that little bit where it goes down is that Q. That's kind of that charging. Our R is the actual electrical release or the contraction. Our S is kind of the reset, and our T is the whole heart kind of resetting. There is actually kind of a reset with P, but it's so small, and QRS is so big, we don't really see that. But we'll always have those things. Some of the numbers we need to know about is our QRS complex or QRS interval, and that's the time from the Q to that, or the whole ventricle, is normally going to be anywhere from 0.04 to 0.12 seconds, or one itty bitty box to three itty bitty boxes. When we talk about electrical arrhythmias, if it's a long or wide, that can be a sign of electrical activity. And our ventricle rhythms, VFib, VTach, eventually when you learn SVT, these will be wide. And so that's what that tells you. And when we're talking about breathing electrical rhythms, we need to know that. So 0.04 to 0.12 seconds. That's the QRS. My QT interval is from the Q, that's the entire ventricle, the contraction and the reset, and that's from 0.4 to 0.44. So we have a very small range within that. There's one more we're going to talk about in a little bit later. We'll talk about that. Those are the numbers we need to know. We also need to know where to place our heart rhythm straights to make sure we're getting it. We have RA for right arm, LA for left arm. And then you have V1, 2, 3, 4, 5, 6, having the areas of knowing where to place it. So these are the only 6 heart rhythms you need to know for the test. Again, these are the only 6 heart rhythms you need to know for the test. And I'm going to go through, similar to when we talked about ABGs, we're going to give you the skills and the resources to be able to read them. For some of these, we can give you hints or tips, and some of these are very accurate. But I don't expect most of you to be able to look at a heart rhythm and know exactly what it is. But there are 4 questions we're going to go through. And if you ask those 4 questions, you're going to know exactly what heart rhythm we're talking about. So before we talk about the super fun stuff, we're going to talk about our risk factors. Patients are more likely to have a dysrhythmia. It's one of the 6 we talked about if they had a previous heart attack, if they have hypertension, heart valve disease, heart failure, disease of the heart muscle, infection, diabetes, history of sleep apnea, heart surgery, any electrolyte disturbance, any recreational drug use, and drug toxicity such as digoxin. So pretty much every single heart arrhythmia we're going to talk about is going to have the same symptoms because the heart don't work. So these just tell you there's a heart problem. We're not going to know which dysrhythmia we have until we get an EKG. Because again, this and certain vital signs are just going to tell you something's wrong. Palpitations, hypotension, anxiety, sweating, shortness of breath, fainting, lightheadedness, dizziness, weakness, and fatigue. So the 4 questions I want you to ask for each heart arrhythmia is, what is the rate? Is it normal, over 100 or fast tachycardia, or less than 60 bradycardia? Is there a regular, consistent rhythm, or is it all over the place? 3, is there a singular P wave with a singular QRS? Or do we have a monogamy? I want every P wave to have a QRS and every QRS to have a P wave. And then the last one is our QRS normal or wide? And I told you there was another number we would talk about. Our normal QRS should be 0.12 to 0.20, or 3 itty bitty boxes to 5 boxes, or 1 big box. That should be our normal range. So we have those numbers. That's our QRS. So here we have an example of a normal sinus rhythm. Now, this one, the EKG is kind of blurred behind it, but if we go through it, we have, first thing we're going to do is count, and we know it's a 6-second strip. So what we're going to count is I usually do our QRSs because they're very visible, and I'm going to count how many there are. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9. And I know if this is a 6-second strip, 6 times 10 is 60, so 9 times 10, we got a heart rate of 90. So this is a normal heart rate. It's between 60 to 100. So we have a normal rate. Second question, is it a regular rhythm? And the way we can solve this is if I can find a number or a line. Let's do this one. Now, okay, fine, do that way. But I should be able to measure from one QRS to the next, and if I were to pick it up and move it, it's going to be the exact same distance. And what I would do is I'd get a little piece of paper or a marker or something, and I can find that. You could also do from one P wave to one P wave, or one T wave to one T wave. However you want to do it, it should be the exact same distance. That's how we know it is a regular rhythm. The next thing I'm going to look for is there a single P wave with a single QRS. So every P wave should have a QRS, every P wave with a QRS, every P wave with a QRS, so on and so forth. And we have that. We don't have extra P waves, we don't have extra QRSs. And then the last one, the QRS should be 0.12. I'm so sorry, there was a typo. Our P wave is 0.12. I'm so sorry. I did not mean to confuse you before. I was reading the wrong one. QRS, it should be less than 0.12. I'm so sorry. So QRS should be less than 12 or 3 itty bitty boxes. And once we get to a better one, I'll be able to show you and break it down. And so for sinus rhythm, we're not really going to have any abnormal symptoms. Our heart rate is going to be within the normal range. We don't really need to do anything. So now we have sinus brady. Now again, we're going to ask ourselves 4 questions. 1, what is the rate? And we know this is a 6-second strip. So I'm going to count 1, 2, 3, 4, 5. 5 times 10 is 50. And we're like, that is less than 60. So it is not a regular rhythm or not a normal rate. Therefore, I know it can't be sinus rhythm. Second thing is, again, I am going to draw my lovely line, and I should have the exact same distance from one QRS to one QRS. Oh, it should be exactly the same, exactly the same, exactly the same. I could also do one T wave to one T wave, or one P wave to one P wave, but it's going to be the exact same. So we do have a regular rhythm. Next question, question 3, is there one P wave with one QRS? Every P wave has a QRS, every QRS has a P wave. And then the last one was is the QRS less than 0.12 seconds? So if we count, this has the box. We have 1, 2, 3, which is exactly 0.12 seconds. So that is normal. If the QRS is wider than 0.12, because again, we said it was 0.04 to 0.12. If it's more than that, that tells me it's a ventricular rhythm, whether it's VTAC or VFib, and we'll talk about those in a little bit. These are caused by something irritating it due to decreased coronary perfusion. It could be an irritant. We don't have the right stimulus. Certain medications like our beta blockers can cause that, increased intracranial pressure or intra-abdominal pressure, electrolyte disturbances, cardiac disorders, neurological disorders. Oh my goodness, we have a lot of the symptoms we talked about: restlessness, anxiety, confusion, dizziness, syncope, shortness of breath, diaphoresis, chest pain, hypertension, all those lovely, lovely things. So I did forget our medications. We got our beta blockers, calcium channel blockers, our opioids and benzodiazepines, lithium, ethanol, which is an alcohol, and digoxin. Digoxin works because it makes the heart more efficient. So as a result, the heart doesn't have to be as fast, but it can cause bradycardia. Our increased intra-abdominal pressure is going to squeeze the heart, makes it harder. This could be from vomiting, NG suctioning, or vagal stimulation. Uh, Ocular pressure within the eye could also cause intracranial pressure, severe pain, and hypoxia. High potassium is the most common electrolyte disturbance that can cause bradycardia. Cardiac disorders can be our myocardial ischemia or infarction, you have a heart attack, or decreased blood flow. Our healthy athletes tend to have bradycardia. It's just not symptomatic. And a super fun one is the Lyme disease you can get from ticks can have this. We have our symptoms. So my first thing is going to be determining, are they symptomatic? Am I concerned? Are they having severe symptoms? If they're not, we're just going to continue to monitor. If we are, we're going to focus on oxygenation and monitoring, because usually the symptoms are due to lack of oxygenated blood getting to the tissue. We're going to monitor blood pressure, monitor heart rate. We can give them atropine. That's going to increase the heart rate. If it's bad enough, we are going to pace the heart, which is the fancy way of saying we're going to give you and we're going to shock you. So you can do what's called temporary or our skin, and that's where you put our patches on for your code rapid or something like that, where wherever you have to shock them, you can actually change it to pacing. That will give them a slight electrical activity. Or we're going to take them to surgery and put in a permanent pacemaker. If it's a new onset, they've never had this before, and it's symptomatic, we're going to call the doctor, we're going to call a rapid response team because we want to fix it. If it's been pre-existing, the doctor knows about it, or they're not really symptomatic, we're going to monitor. And we're only going to notify the doctor if it's getting outside of a normal level for them, normal for them, or if the symptoms are getting worse. For example, I had a patient who came into the hospital with known bradycardia, and whenever he slept, he would drop down into the 40s. And I was very concerned. And we had a rule that we needed to call the doctor if it dropped less than 40. So what we would do is we would wake up the patient because he was asleep, and someone would be watching the heart monitors, and it would pop up, and we're like, "We're good. Go back to sleep, Mr. Smith. Okay, good night." And although he didn't like being woken up, we were like, the heart didn't stay low. If it did, we would have had to call a rapid or code. All right, so we have sinus rate. Now we have sinus tachycardia. Again, we're going to ask the four questions. First one, what is the rate? And again, we're going to count because we have a 6-second strip. I got an 11. 11 times 10 is 110. So we're over 100. So we have fast rate. Second question, is it a regular rhythm? And I'm going to do that by calculating with my lovely line. And it should be from one to the other one. And again, I can pick it up and I can move it. And it should be the exact same distance from one to the other. Third question, is there one singular P wave with one singular QRS? Yes. Is the QRS less than 0.12 seconds? And if I look here, it's just one itty bitty box, so 0.04. So we are good. So everything's normal except the heart rate is faster than 100. We got our sinus tachy. Things that can cause sinus tachycardia usually are caused by some other conditions. So certain medications like our albuterol or breathing treatments, our epinephrine. A lot of times it's caused by a condition. So, for example, you have an infection, we're going to have a heart rate. You're in pain, we're going to have heart rate. An allergic reaction, heart rate. We could also have certain cardiac disorders. Cardiac disorders could be congestive heart failure, shock, pericarditis. Those could cause elevated heart rate. Alcohol and caffeine can both cause the heart rate to be up. Stress response, whether that is, oh my God, there's a stranger outside my door at midnight, or it's Miss B asked you a question, everyone's looking at you. Anxiety and electrolyte abnormalities could be either potassium or magnesium, can both cause tachycardia. Other things include any kind of damage to the cardiac tissue. Thyroid problems can cause it as well, but again, we want to know what's causing it. Symptoms. Oh my God. Are these almost the exact same symptoms as sinus bradycardia? Yeah, because the heart's not working right. Most common difference is they'll feel like their heart's racing or pounding out of their chest, but a lot of these are going to be almost identical. So, again, my first thing is, are they symptomatic? Are they stable? What is their blood pressure? What is their oxygen status like? What are their symptoms? If it's a new onset, we're going to fix it. And again, 9 times out of 10, it's caused by something else. So it's caused by low blood pressure because of anemia, or it's caused from a fever. And if I fix that underlying condition, that should go away. If it's well known or pre-existing, we're going to monitor and only call the doctor if it's abnormal. We can do, it's called the vagal maneuver, and have the patients bear down like they're trying to poop if they're constipated, and that will actually put pressure on the heart. We could also give them medications to slow the heart. And the other most common drug is adenosine, which is a really scary drug. It kind of resets the heart or restarts it, and we're hoping it restarts properly. But 9 times out of 10, if we fix the underlying cause, it will go away. All right, next one we're going to talk about is AFib, or atrial fibrillation. Fibrillation is a fancy medical term for saying quivering or spasming. And what happens is the atrium contracts multiple times before the ventricle goes. And we'll see this because we'll usually have bumpy. So the first question we're going to ask is, what is the rate? And we have it here, 9. The rate can be up to 400 beats or more. If you've ever put a pulse ox machine or pulse oximetry on a patient who has AFib, usually you'll see their heart rates constantly changing. It'll go from 80 to 120 to 64 to 96, and it's all over the place because the ventricle is waiting for its cue from the atrium, and we're having a couple. So the rate could be fast, slow, or normal. The second question is, what is our rate? Is it a normal, regular rhythm? So for here, we on here, and if it's a normal, regular rhythm, I should be able, I don't want to do that. I should be able to pick it up. Come on, you're working so good for me. Oh my goodness, it is not the same distance, so we do not have a regular rhythm. So that's a no. This is the first rhythm we're talking about where we don't have a regular rhythm. Third question, is there one singular P wave with one singular QRS? I'm like, no. This QRS has like 3. This one I think just has the 1. This one has 4. This one has 2. So we don't have that 1-to-1 ratio, so that's abnormal. This is sometimes called an F wave. We can't really measure the PR because the PR is the distance from the first and only P wave to the top of the R. So we can't do that. Our QRS is still less than 3 itty bitty boxes or 12 seconds, but we can see our abnormalities. And again, this is because of that. So when we talk about this, there's quite a few things that can cause AFib. Chronic heart failure, heart disease, chronic hypertension, ventricular hypertrophy, rheumatoid arthritis, toxicity of our thyroid, cardiac surgery, acute pancreatitis, sepsis, chest trauma, lung disease, hypertension, diabetes, older adults, obesity, chronic kidney disease, alcohol use, smoking, ancestry. We don't know why, but patients who are of European ancestry, England, France, Germany, uh, Belgium, all those are more likely to have AFib. We don't know why, but that is a fun thing about AFib. Our symptoms are going to be almost the exact same as bradycardia and tachycardia, because again, the heart don't work right. Some patients have absolutely no symptoms for AFib. It's asymptomatic. But the symptoms, if they're severe, can be here. So what's the first thing we're going to do? Same as everything else. We're going to assess, are they symptomatic? What's going on? How long has it been going on? If it's asymptomatic, they're not really having a symptom, we're going to give them a blood thinner. This reduces the likelihood of clots because if you remember, we talked about earlier in the PowerPoint, if the blood is sitting still, it tends to clot. So I'm worried about the blood that's in that atrium, and the atrium's not having a good contraction. So a little bit of the blood is just sitting there and it's going to clot. And then when they finally have a good heart rhythm, it swings, and now we have a floating embolism, a future heart attack, stroke, pulmonary embolism, something. If they're symptomatic, we are going to give you a medication to treat the arrhythmia. Our antiarrhythmias are going to be tiltazem, our, oh my goodness, I'm so sorry. Antiarrhythmias are going to be amiodarone or diltiazem. We might even do digoxin just to try to make it more efficient. We're usually also going to give them a beta blocker or a calcium channel blocker to try to sometimes slow it down, but also just help that electrical activity move. We can do what's called a cardioversion, and then again, that's where we shock them into hopefully a better rhythm. Ablation is the fancy way of saying we are going to burn or cauterize the tissue because we know the heart works that if one of the pacemakers is not working, another pacemaker can take over. And the hope is if we destroy those specific pacemakers that are causing issues, the next couple that take over won't have arrhythmia. But all of this goes back to, are they symptomatic? And again, if they're symptomatic and they weren't before, we're going to call the doctor, we're going to call a rapid because we don't like symptomatic changes. If they're asymptomatic, we'll notify the doctor and monitor, probably going to put them on blood thinners. But again, we're going to go back to what are the symptoms, what's going on, how long is it happening? All right. Now we get to talk about VTach, so ventricular tachycardia. Again, we talked about before, we're going to have our ventricular rhythm, so it's being controlled by the AV node, and we have a heart rate over 100. So first thing we're going to do is count the rate. We have a 6-second strip, and we're going to count. I'm not going to count this one because it's not all there. So I got 14, which is 140. So VTach is usually going to be anywhere from 140 to 180. But for your testing purposes, if it's over 100, it's fast. Second question is rhythm. We're going to have the same distance from one to another. I can't do from one P wave to one P wave because it's not there, but I can do from the top. And it's going to be the same distance. Oh, look at that. But we do have that regular rhythm. There's not going to be a P wave with the QRS because there usually is little to no atrium. Sometimes the atrium is contracting, but it's just not visible because of that. Um, and the QRS is going to be wider than three itty bitty boxes or um, 0.12 seconds. So, for example, from here to here, we got 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 itty bitty boxes, which is pretty big, and you can tell it's noticeable. Sometimes some people will describe this as tombstones, almost like if you're looking at it in a car and you're past graveyard. Another one I think about is you got a little kid who's like, "Mommy, Mommy, look, I can write the letter M." And it will usually look like that. Not always, but it is a sometimes pretty noticeable. But again, our four questions. We're gonna have fast heart rate, regular rhythm, no noticeable P waves, and the QRS is gonna be wide. So when we talk about our causes for our VTAC, so VTAC can be caused by ischemic heart disease or valvular heart disease, heart attack or MI, cardiomyopathy, heart failure, hypotension. Uh, Drug toxicity, such as steroids, can cause a VTAC, as can low potassium and low magnesium. Also, cocaine users and our patients who had to illicit drugs. Your book talks about patients who sniff paint or sniff cleaner. My favorite story about this was we had a patient who came into the hospital with heart palpitations, and we saw noticeable VTAC. We started doing the history of what happened, and he told us he snorted cocaine in the parking lot. And I was like, that could do it. So we got to know what causes it. Again, my highest priority is going to be, is it symptomatic? There's two big talks of VTech and two big differences. They have a pulse, they do not have a pulse. If they have a pulse, they're talking to you, they're conscious, we are going to monitor. We are going to usually, for that one, we're going to give them oxygen. We might give them amiodarone or lidocaine. And we're possibly going to cardiovert them. You can do that while they're conscious to try to shock them into a good rhythm. If they do not have a pulse, the heart is working so incorrectly or so fast, the muscles can't keep up, we are going to do CPR because at that point, they're not working. You're pretty much going to know. So we're going to call code blue if they do not have a pulse. Now, if we're testing them and they're talking to me, I'm going to say they have a pulse, even if I can't feel it because they are conscious, they are talking to me. Um, but again, that's a big difference. If they have a pulse, oxygen, amiodarone, lidocaine, slow that heart down. We're going to cardiovert them or ablation. We are going to get that heart working. If and when they do not have a pulse, CPR, defibrillation. Again, ABCs, level of consciousness, oxygenation, and the big thing is, do you have a pulse? Are they conscious? Do you not have a pulse? All right, so VFib. VFib, we got a super fun one. Our four questions. What is the rate? The, there is no rhythm. Uh, is it a regular rhythm? No. Is there a singular P wave with a single QRS? No. Is your QRS normal or wide? No. So for this, if we said our VFib was your kid saying, hey, I can draw the letter M, our VFib is squiggles or doctor's handwriting, however you want to say it. But that is nothing. Okay? Nothing. So if we have this, my first thing I'm going to do is, you okay? I'm going to go in and put eyes because I have had it happen before where the patient has been scratching or several of the sensors came off and it reads as VFib. But my highest priority is, are you okay? So things that can cause a VFib are things such as coronary artery disease, heart attack, low potassium, low magnesium, severe bleeding. We have our rapid SVT or supraventricular tachycardia. That is a heart rhythm you're only really going to know if you do advanced cardiac life support. severe shock, certain medication, or severe trauma, aka surgery. So, one of the few times our symptoms are going to be different. Patients with VFib have no heart rate, they are unconscious, they have no respiratory rate, no blood pressure. The only thing going on is they have low but present pulse oximetry because at a certain point they were working. Our patient is going to be dead in 3 to 5 minutes. So, my highest priority is get them working. So I'm going to assess because again, they could have be fine and it's an EKG rhythm. And we are going to defibrillate them. We are going to do CPR. CPR is going to keep them alive, and defibrillation is going to hopefully get that rhythm. Even though it's the worst rhythm we can possibly have, they do have a rhythm. So we are going to shock it because anything is better than VFib. We really couldn't really do worse. So we are going to shock them. We are going to do CPR. We are going to make sure they're full code because if they're not, we're not going to do any of those. But assuming we are, and we are going to get them into a better rhythm and we are going to get them conscious. Probably, maybe need to get a pacemaker, something else. Asystole, similar to VFib, all my answers are going to be no. There is no rate. There is no rhythm. There is no single Q wave with a single QRS, and the QRS is not there. But we can see a noticeable difference. Asystole is usually caused by severe abnormalities. We have our H's, hypoxia, hypovolemia, hypothermia, acidosis, hyper or hypokalemia, heart failure, tension pneumothorax, toxins, tamponade, and thrombosis. But either way, there is a no electrical activity. So they are unconscious. They are on their way to being dead if they're not there yet. No pulse, no breathing, no blood pressure, no pulse ox. Unlike a VFib, these patients are going to be dead in 3 to 5 minutes, depending on where you found them. My first priority is again assess because I have run into a patient's room. Telemetry's called me, your patient's in asystole, and find the EKG has been taken off and they're in the middle of the shower. So I need to confirm the rhythm. I'm going to do CPR. We tend to not shock them. The rationale is if I shock them, everyone's taking their hands off their patient and we are not doing CPR. And for those 15, 20 seconds, they are not keeping them alive. So our highest priority is airway, CPR, all of that stuff. We're going to give them epinephrine. We're going to try to figure out what it causes. But okay, if you do advanced cardiac life support or you have before, a lot of times they'll tell you to shock because what are you going to do? Kill them? But the book does emphasize that for that moment, um, even though shocking won't necessarily hurt, it's taking time away from doing CPR. So best case is CPR until we get a rhythm, even if that rhythm is VFib. You know how I said almost nothing is worse than VFib? Absolutely nothing's worse than asystole. They are dead unless we fix them. So we want to be able to intervention. Last thing we're going to talk about for type 1 is pacemakers. And we talked about before we have our temporary and our permanent. So our temporary would be our transcutaneous. That's when we put our patches over them and we can use that to shock them or defibrillate, or we can use it and you switch the dial to pacing. Transvenous is really going to be, so a ventricular pacemaker is going to shock right before the ventricular. Our atrial pacemaker is going to shock right before the atrium, and our dual chamber will shock with both. Pacemakers are usually on the left side of the chest. They're usually, they can be put on the right. It's not as often as it's as big as a cigarette case or a cigarette container. They are getting smaller and smaller, but we want to know it. This is why we'll also tell our patients to have an armband, because if you think about for CPR, you don't want to put your pad right over a pacemaker. Some pacemakers pace, some can also defibrillate or shock the patient, and there's two modes. There's demand pacing or asynchronous slash fixed. My asynchronous or fixed rate is the heart is going to beat exactly at whatever the doctor programmed it, 65. And so there is going to be a pacer spike and then heartbeat immediately. My demand or My pacing, my demand or my pacing is going to have a range. So as long as they're between 60 and 80. So if it drops below 60, there'll be a shock to kind of reset them. If it goes above a certain thing, it'll be a shock to reset them. So it kind of has a range. One thing we do want to keep in mind for pacemakers is if I have a patient on a pacemaker, think back to our cardiac output is stroke volume times heart rate. The pacemaker is going to prevent the heart from compensating. So, for example, if their blood pressure is low, their heart rate's not going to go up because that pacemaker is going to prevent it. So that's something to keep in mind when we're talking about our safety. You are not going to be tested specifically on pacemakers, but for clinical and for future nursing care, we want you to know what it looks like. So for here, we have that straight line, and that tells you that electrical pacemaker because it's going to be just a very short straight line. And immediately after that, we have the ventricular rhythm. I know it's ventricular because it's wide. So this top one would be our ventricular pacemaker. Our bottom one, I know it's atrial because I have the line, and immediately after that is the atrium and then the QRS. And so you'll see that short straight line, and then immediately after that will be either P wave or QRS wave, depending on which one it is. And that's way you'll know what it looks like. After a pacemaker placement, we gotta have some teaching because usually they are going to cut open the ribs and the muscle. So they can shower and bathe once it's healed, once it's intact. We want them to have a pacemaker with them, the ID card. We don't want them to lift up anything heavier than 10 pounds for the first 4 weeks. We need to monitor for signs and symptoms of infection, internal bleeding, dehiscence, and evisceration. The cell phones is an interesting thing. We're like 90% certain that if you hold up an electronic device like a cell phone or you're right next to a microwave, that it won't interfere with the electrical activity, but there's no ethical way for us to test that. So that's that whole idea. We're again 90% sure, but there's no way to be like, hey, you have a pacemaker. We want you to have this phone right next to you and see if you're die. Well, we can't do that. That's not ethical. So that's just our better safe than sorry kind of idea. Going with that. All right, and that is part one.